What if I told you that you didn't have to talk to neurosurgery anymore? You no longer had to make that phone call. You know the one. It doesn't seem necessary, but you're forced to do it. But that doesn't save you the attitude from the consultant. But what if we could just stop making those calls? Could that make you love evidence-based medicine? Let's talk about the big guidelines. Welcome to First 10 EM. Hello. Welcome back to First 10 EM. Today we're going to look at the brain injury guidelines. And before I alienate any wonderful physicians out there, let me just say I have had some very wonderful conversations with neurosurgeons in my career. Even at 3 a.m., I've had conversations with caring clinicians who are not only outstanding medical experts, but who are clearly compassionate about the patients that we are co-managing. But for whatever reason, most emergency doctors I know dread calling neurosurgery. The interactions just never seem to be as cordial as we would like. And to be fair, if I was forced to take hundreds of basically pointless phone calls every single shift, I might get a little bit snippy as well. I see a ton of patients who have minor head bleeds that I know aren't surgical. I don't want to call the surgeon. I don't want to waste everybody's time. I know the plan. Admit the patient for observation, perhaps a repeat CT scan in 24 hours. Why do I need to bother the incredibly busy neurosurgeon to tell me what I already knew? But unfortunately, I don't admit patients, and the admitting team at every hospital I work at demands a neurosurgery consultation before that admission. So the emergency doctor tends to get caught in the middle. And there are many ways that we could fix this problem, but let's talk about one option. The AAST, American Association for the Surgery of Trauma Brain Injury Guidelines, or just the big guidelines. The point of these big guidelines is to give us some clear criteria for patients that either need or don't need hospitalization, repeat head CT, and neurosurgical consultation. So let's have a look through the guidelines first. We'll get them up on screen here. And then we'll talk about the study that brought them to my attention and whether or not they're ready for day-to-day use. So there are three categories. We have Big 1, Big 2, and Big 3. And you always get assigned the highest category based on our clinical findings. In other words, you need to satisfy 100% of the listed criteria to count as Big 1 or Big 2. If you don't satisfy 100%, you go up to the next highest category. Now, in terms of management, the high-risk Big 3 category gets everything. They get neurosurgery consultation, admission, repeat head CT. Big 2 is our moderate risk group. They get admitted, but it says that they don't need a neurosurgical consultation and they don't even need a repeat head CT. And then Big 1, the low risk group, this would be a massive practice change for almost all of us. They don't need anything. They say observe them in the emergency department, 6 hours, and then just send them home. No phone call, no repeat CT scan, no nothing. And there's way too many of these criteria for you to memorize, especially seeing as, spoiler alert, they're probably not ready for prime time yet. So I think you're just going to go and look up the details anytime you're wondering about them. I think the key features to focus on. Any abnormality on the neurologic exam is an automatic high risk or Big 3. So to be considered low risk, you have to have a perfect neuro exam, and that makes sense. Intoxication is going to make you at least moderate risk. You can't be Big 1 or a candidate for discharge if you're intoxicated. You need admission. But intoxication doesn't mandate a call to a neurosurgeon, and that makes sense to me. And every patient with any form of anticoagulation and with any form of antiplatelet is high risk according to these guidelines. And so any antiplatelet medication automatically gets a phone call to neurosurgeon. Now, I'm not sure if that makes sense, honestly. We don't do anything about their Plavix. We know that platelet transfusions are a bad idea. So what exactly is the neurosurgeon going to do in these cases? I don't know. I mean, clearly these patients need observation and probably the repeat scan, but I don't know that they need the neurosurgeon involved. However, that might depend a lot on where you work. If you're 8 hours from the closest neurosurgeon, it might make sense to observe the patient who's at high risk of deteriorating, closer to where the neurosurgeon actually works. So talking to them early makes sense. But if you're down the street in a big city like I am, it's probably overkill to transfer all of these patients. Aside from these clinical features, the groups are really just divided up based on the size and the type of bleed, and my guess is you should just look up these criteria most of the time, but the numbers make sense to me. Trace traumatic subarachnoid definitely does not need me to call a neurosurgeon. I know that, and the neurosurgeon knows that. Unfortunately, our medical system doesn't seem to know that yet, and that's why I think these guidelines, or some version of guidelines like this, are going to have great potential at some point. All right. But are these guidelines any good? What is the evidence here? So this paper, Joseph et al. 2022, from the Journal of Trauma and Acute Care Surgery, it's a prospective observational trial looking at these guidelines, and they included just over 2,000 patients from 10 trauma centers in the United States. 15% got classified as low risk, that big one. 15% were medium risk, big two, and that leaves 70% who were high risk, as big three. And the outcomes? No low-risk big one patients had any neurologic deterioration, and none required neurosurgical intervention. So that's really good news. But unfortunately, this paper presents no stats at all, so we have no idea how high the 95% confidence interval might extend here. But given that this big one cohort only had 300 patients, it's probably pretty high. There were also 1.3% of patients in the big one group that had worsening of their bleed on a repeat CT scan. And there was one patient who had a readmission within 30 days, but the authors tell us that wasn't related to the traumatic brain injury. For the moderate group patients, big two, only 0.7%, so still very low risk, had any kind of clinical deterioration. And although 7% did have progression of their bleed on a repeat CT scan, none of these patients required a neurosurgical intervention. And then big three patients were high risk exactly as expected. 16% deteriorated clinically, 21% had progression on a repeat CT scan, and 20% ultimately had some kind of neurosurgical intervention. Now, the real outcome of interest in this study was a need for neurosurgery, and there was no neurosurgery in either big one or big two patients. And that's a real win for these guidelines. However, I imagine the other numbers might feel too high risk for most docs, at least right now. Big two still had a 7% rate of progression on their repeat CT scan, and even big one had a 1.3% risk, and that's not accounting for 95% confidence intervals. So the risk of worsening might just be too high to warrant skipping that repeat CT scan based on this data. But with no need for neurosurgery, you could also ask, who cares what that repeat CT scan looks like? And then to round out the data, they tell us that implementation of these brain injury guidelines would have resulted in 425 fewer repeat CT scans, 401 fewer prolonged hospitalizations, and 511 fewer neurosurgical consultations in this cohort of 2,000 patients, which sounds pretty good. Now, there are some obvious issues with this study. First, a couple of things that might make you worried that the complication rate might actually be higher than suggested. Not everybody here got the same workup. Not everybody got repeat CT scans, so we might have missed some important injuries. Also, there were too many patients here who were lost to follow-up or excluded because of missing data, and even one or two missed outcomes could dramatically alter these results. And again, they present these numbers without stats. There's no 95% confidence intervals. But it's really that high end of the confidence interval that we really care about. A 0% neurosurgery rate sounds great, but it sounds a lot less great if the range of estimates is a 0 to 5% miss rate. Now, on the other hand, there are a number of factors that suggest that this study might be overestimating the risk for the average emergency department patient. These are trauma center patients, and it sounds like they're sick trauma center patients. Like 20% were getting blood transfusions, so these aren't simple isolated head injuries. There's referral bias here. And so the average isolated head injury patient in my community emergency department is almost certainly going to be a lower risk than the patients they included in this study. However, these patients were monitored at experienced trauma centers. They were all admitted under trauma teams. And so, 24 hours of neuromonitoring in a trauma center might be very different than the same monitoring in a rural hospital with only a single nurse working in the entire building. The point is, this data is great, but there is a ton of uncertainty here. Look, I love where these guidelines are going, but I don't think we need to be this aggressive right off the bat to still have a massive beneficial impact. Am I sending home all these low-risk Big 1 patients right now? No, absolutely not. But a 24-hour observation period without neurosurgery consultation and without a repeat CT scan is still a big decrease in resource utilization from what we're currently doing and is almost certainly justified by the findings of this study. For the moderate risk patients, those Big 2 patients, I agree with the guidelines that they don't need immediate neurosurgical consultation. You can save that for if they deteriorate or if their CT scan gets worse. But with a 7% rate of progression on CT, I think repeat CT scans still might be warranted. We could debate that though. And, if we're admitting these patients anyway, that doesn't seem like a big ask. But just those 2 steps, I think, would be fantastic. They would start the process of decreasing resource use in these high-risk patients, while at the same time keeping our patients safe, considering the limitations on this evidence so far, while we wait for further studies in this area. But I guess the real question is, can we get buy-in from our admitting teams? Because I think emergency medicine will accept this in a heartbeat. But ultimately, we don't get to make these decisions. That's it for this time. Be sure to watch out for the Broom Docs podcast this month, where me and Casey Parker will discuss this paper in a little bit more detail and check out the full write-up on first 10 EM. For now, take care.